I'm Jason Yan from Hong Kong, and today my co-chair is Winston Prakash from UK. We have various topic on today on eye health in children from myopia, eye disease screening, and low vision, etc. So today we will have our first speaker. Professor Sautel May, well-renowned speaker and researcher in myopia and public health. She will share with us on the topic light outdoors and myopia in children. Professor Saw, please.
Thank you for the invitation to speak. It's a very kind introduction from you, Jason. So this symposium is on children's health in, regarding the eye, but I will speak on myopia, which is quite a big problem in other parts. I've got some financial disclosures as seen on these slides. So we know that myopia is a disease very common in large urban cities. I think we see that in India as well, and the rest of Asia, for example, in Korea, Japan, Singapore. And we know the burden is huge because it can cause myopic macular degeneration. In Singapore, the myopia rates have been very high for the past 30 years, so for a long time. And the prevalence of myopia in young male adults, because we refracted the military conscripts, is as high as 86%, and it's been remaining about the same, quite stable, maybe a bit lower by now. There have been several studies, so I've been privileged to collaborate with my collaborators from China. So they've looked at 82 studies in China and the pooled prevalence of myopia, and that's all refraction encyclopedia. And we see these rates as a summary. So in children less than 4 years is about 2.6%. In children 5 to 9 years, 22%. 10 to 14 years, 45%. And 15 to 19 years is already 67%. And the projection is that the myopia rates will increase in both urban and rural China, although the difference between urban and rural areas has decreased quite a bit, and we will see that increase in the next few decades. We also have seen rising prevalence of myopia for a long time. So for example, these data are from Japan, 1912 to 1937, we see these rising rates. And in Singapore, we see a sudden rapid rise, where it was only about 30–40%, in the 1940s and 1950s. But it's not a gradual rise like in the Western countries. The sudden rise in the 1970s and 80s, and then suddenly it shot up to about 80% in 1996. So with this sudden rise, we see an intergenerational difference in myopia. I'm not sure whether this will happen in other countries where the rise in myopia is more gradual. So I'm going to talk about the environmental risk factors for myopia, but to summarize, there are two major environmental risk factors for myopia. The first, the lack of time outdoors, and the second is too much near work, which could be reading and writing from the paper or reading and writing from the screen, what we call screen time. And of course, the small, tiny, minor genes that may cause myopia as well. And we see here, for example, I'm just going to focus on outdoor time, and we see here in this study by Lisa Jones that, this increase in myopia as they spend less time outdoors. So there's the hours playing sports and how that interacts with the number of myopic parents. And we know from many randomized controlled trials have proven once you have an outdoor intervention that the incidence rate of myopia is lower, and spending more time outdoors doesn't really affect the academic performance of the children. So they're still doing very well in school. So parents may not have to be concerned about that. And we have got other studies, for example, the study in Shanghai, China, 6,000 children, where in the intervention arm, they spend an extra 40 to 80 minutes outdoors, and the light meter has measured the light levels in lux, and we see that the myopia rates have decreased with this outdoor intervention, and with the outdoor intervention, a higher light level. So I'm going to talk about something more technical now. It's our two inventions. Firstly, we have a fitness tracker, the FitSight, that can document light and outdoor patterns every minute. And secondly, we worked with the engineer, and we have developed a child mannequin with a light meter in the eye socket. So starting with the outdoor fitness tracker, we invented that in 2014. So it's a standalone prototype, minute by minute, light levels and lux telling us whether they're indoor or outdoors, or it can be added to a smart watch, for example, and an app that can track the light intensity and time outdoors as well. So this is a typical slide of a child, and we see here the time spent indoors in school. The light levels are very low, a few hundred lux. And then when the child is outside during recess, it suddenly shoots up to 26,000 lux. This is when the child is walking home, but the rest of the time, a child in Singapore spends a lot of time at home. So you see the child is watching television and then doing homework and going to the cousin's house for dinner. So in urban countries such as Singapore, we see that the lifestyle is very indoor-centric. And that's a weekday. So you say, oh, that's a weekday, they're hardly outside. Well, that's true. So on the weekend, the children try to bring the children outside. So this is already very good for a Singapore child to be exercising in the park. But the rest of the time when the child is indoors, we see these very low light levels. So the very low light levels are a problem. And we have children wearing the FitSight tracker maybe for 7 days. And we see here that the mean lux level is very low, only 731 lux. And the maximum lux level is only about 31,669. So I'm going to talk about a birth cohort that we launched and the children are about 15 years of age now. We started a birth cohort in Singapore, but at the age of 9, we see that we have used this FitSight watch, and we have a diary and a questionnaire and cyclopedic reflection to look at the relationship between outdoors and myopia. So we see near work, which could be reading, writing, screen time, and this is the distribution. Then we have outdoor time, and we see that variation as well. But we see here, it's not really true. If they spend more time on near work, they will actually spend less time outdoors. We have children, I don't know how they do this, but they spend a lot of time on near work and a lot of time outdoors. And then we have children who don't do anything at all. They hardly are outdoors and hardly do any near work. Maybe they're sleeping. So it's not the inverse relationship. They're both independent factors. And with the diary, we have a clear idea of what they're doing. Most of the time, nothing much. Just you think that they're really doing some vigorous exercise, but the children are quite simple. In Singapore, they're just playing, walking, swimming, because we're a tropical country. And when we look and track the light measures minute by minute, as expected, the light levels are much higher at the noonday. And we found that for every minute and hour increase in outdoor time, regardless of the light levels and the light patterns, the myopia rates will decrease. We also compared our results with the results in Australia. So this is in Brisbane, it's Scott Reed in Brisbane. And then we see across, and they also have a light meter, so across the time of the day, and when we compare the number of spurts, we always see that in Singapore, the outdoor time is always consistently much lower than in Australia. And we know, for example, in Brisbane, that the myopia rates are much lower in Brisbane, Australia. And we're also looking at green space, and this is a study in China looking at myopia rates and green space. And of course, if you're near more green space, then you spend more time outdoors, and myopia rates will be lower. There is also this glass classroom that was invented, and it's in Guangzhou, and we see that the light levels are quite high, but it's not easy to engineer and design. It's very expensive. This sort of classroom where you allow the sunlight to come in and the light levels are higher. We also have got, family walks and all that, nature parks in Singapore, so that's quite successful. And then we have a very good national myopia prevention program by the Ministry of Health to educate and encourage the children. Okay, but if I have time, then I'll just end with this study that was funded by Exelor, but we're looking at, people do ask me, if you ask the children to go outside, what about protection for their eyes against cataract and so forth? Can they still wear sunglasses and hat? And I thought, this is Singapore sky, and we did measure, and this is in the university. So our National University of Singapore, we invented this mannequin with the light meter and the eye socket, and the different environments with the mannequin, and indoors as well. So you get indoors with a big window, or indoors with no window. And we know the difference between indoor lighting and sunlight. So the wavelengths are different, and the intensity is much lower indoors. So let's look at the open field where you see these lux levels, very cloudy in Singapore, so across the time of the day, the lux levels, of course, highest in the open field when we place the light meter and the air mannequin, but they don't really decrease very much if the child is under a tree. It does, but still higher than the child was indoors. So even a child outdoors under a tree still receives more light and protection from myopia than indoors. And you know, in the street, it's not very different. It's still better than being indoors. And if you wear sunglasses, and this is, you know, the light meter is inside the eye. If you wear sunglasses, we see also that the light entering the eye is better than indoors. So always go outside, wear sunglasses, and that is still better. Even wrap around sunglasses that protects your eye, but at the same time, the light levels entering your eye to protect from myopia are still higher than indoors, and you know, all types of sunglasses work as well. And even if you wear a hat and you wear sunglasses, which is the orange bar, now of course the light levels entering your eye will be less and lower, which is only about 2000 lux. Is still higher than being indoors, because being indoors, the lux levels from these artificial bulbs, the light intensity is very low. I think right now here, it will be at a light meter only be about 200 lux. So this is a summary of our results of our study, that being outside, even with sunglasses and hat, is very good for you, and should spend at least 2 to 3 hours per day outside, which is 14 to 21 hours per week. So the message is that children should enjoy the great outdoors and continue. If they're really enjoying the great outdoors, they should continue to enjoy the great outdoors. I'd like to thank all my collaborators. Thank you very much. Thank you.
Thank you, Professor Saw. I think we can take 1 to 2 questions after each talk. Any question for Professor Saw? May I ask Professor Saw, for the outdoor is so important, but in Singapore, I see that there's a lot of outdoor because the sunlight is very shiny. But in some regions, the outdoor is not that much. I mean, the lux is not that much. Some geographical consideration or some seasonal consideration. How should we tackle these measures?
What we have found from the Gusto study is all about time. It's a time outdoors, and we don't need very high lux levels. So even though outside it's not very sunny and it's quite cloudy, and the lux levels, even at 2,000 to 3,000 lux, which is not very high, is still better than indoors. So as long as, even I guess if it's a very cold country in winter, as long as they spend some time outdoors during daylight, and even though it may look quite dark with a dark cloud there, it's still, the light levels are still better than indoors. So being outside and out of the walls is still better for the child.
Thank you. And especially in Singapore, the academic stress is so high. I can echo with that, in similar or even stronger than in Hong Kong. So how can you encourage the parents, or from family approach, or from government approach, or school approach for these outdoor activity?
Yeah, I think the outdoor activities have other benefits. For example, the children may be quite stressed, and they might be quite anxious, and they may not have enough time for family bonding. So the outdoor activities improve family bonding, improve the relationship with their parents, spending time outdoors. It also decreases the stress. So if your mental health is better and you're doing well, then you might do better in school. And for the randomized trial in Shanghai, they've shown that they've looked at academic grades. Even if they spend more time outdoors, the academic grades are not affected. And we can see that, for example, in Australia or in the UK, the children are all doing very well, but they're outside as well.
Thank you. Thank you.
Thank you.
Thank you very much.
What is the role of atropine in the case of myopia, especially in the under 13-year age group?
Sorry, can we repeat that again?
Role of atropine in the myopia in under 13-year age. Role of atropine.
Atropine?
Yeah,
Uh-huh.
yeah, in the myopic patient under 13-year age group.
Under 13?
Yeah,
Yeah. So this is, I was talking about prevention, but once a child is myopic, and like you mentioned, below 13 years of age, then one of the treatments that can slow down the progression of myopia is low-dose atropine eye drops, which have fewer side effects as well. So in Singapore, we do prescribe in the hospital myopia clinic low-dose atropine eye drops, but the expert on atropine eye drops is Jason. Yeah, Jason.
Okay, thank you.
Thank you.
Professor Saw, thank you for that wonderful talk. I just had this question, you know, like you presented on the light outdoor impact on the myopia, but in Singapore, did you also have any, you know, I know that the population is quite diverse, Chinese ethnicity versus, you know, different kind of ethnicities. In your data set, whatever you presented, was it mixture of these, or did it have any differentiation between ethnicities?
Yeah, I've shown the data in, I think in military conscripts, we had 15,000 in 1996, and then 20,000 in the year 2000. We have about 78% are Chinese, and then we have a population of Malays and Indians. And we have compared our data in Malaysia in a WHO study. So consistently, in the same country, the rates of myopia are highest in the Chinese, followed by the Indians, and then lowest in the Malays. But the rates in Indians in Singapore is higher than Indians in India, and the rates of myopia rates in Malays in Singapore is higher than in Malaysia. So there's still, because of the environmental influence of the entire country, the rates of myopia are high for all three ethnic groups.
Excuse me, what is the average screen time for the children? Those are the study.
Are you asking about screen
Yeah,
time?
Screen time.
Screen
Average
time, yes.
Does not affect the eye.
Yeah, so screen time, and there's been a large meta-analysis of 300,000 children from many studies. A few meta-analyses have been published, have shown that if children spend too much time on the screen, then the rates of myopia are higher. So we do recommend not more than 1 or 2 hours a day. And if a child is younger, then for example, less than 2 years, we don't even recommend very much screen time. Because the eye is growing and not that mature, it is quite a big problem in some countries, where in the school, also they are switching from reading and writing on paper to digital devices.
Okay, thank you very much, Professor Saw. So the next talk is eye disease screening in children by Zhang Wei He. Unfortunately, Zhang Wei He from mainland China cannot join today's meeting, and we didn't find the pre-recorded video, so maybe we'll move on to the next speaker. Our next speaker is Eye Health in Australia by Professor James Elder from Australia. So, yes, Professor Elder, please.
Thank you, Jason. Thank you for inviting me to present on this. First, a few words about Australia. It's a small country compared with where we are now. A population of 27 million, that's not even the population of the city we're in at the moment. We are have a relatively reasonable birth rate, but less than a quarter of our population is under 15. That's 5-year age groups between 0 and 20, sorry. Australia is a wealthy country, and that obviously makes a difference on the provision of any health service. And typical with lots of countries, the wealth is not evenly distributed. 10% of the population have 46% of the wealth, and the lower 60% of the population have 17% of the wealth. As you can see from this chart, Australia ranks fairly highly in countries around the world with net worth, so a wealthy country. In keeping with that, life expectancy is good. We have diseases of chronic health, and people live for a long time, so a lot of cancers, mental health problems are common in Australia overall. Getting to children, where are they? Well, they're distributed around all the different states of Australia. Just to give you an idea, there's a graph at the bottom of 1,000 kilometres. When I flew here from Melbourne, it was 3 hours and 55 minutes before I went over the coastline. So nearly a third of my flight here was over Australia. The other 2/3 was getting the rest of the way to India. So just under 5 million children under 15. And this looks like they're scattered evenly around the country, more in the east perhaps. But if you look at this population spread, 70% of the population are in the dark blue areas in cities. So in many respects, we're like Singapore. We all live in the towns. And less than 1% live in the vast majority of Australia. That has correlations with disadvantage. So in terms of access to services and things in Central Australia, where only 1% of the population is, it's very hard to access services, though half of our Indigenous population live in that area. They live in areas where it's difficult to access services, so that's perhaps right. English is spoken widely, though nearly a quarter of our population, because we have a lot of recent immigrants, speak languages other than English at home regularly, but only 2 or 3% classified from census data as having poor proficiency in English. What is eye health? Well, it's how well you see, vision, whether you've got healthy eyes and eye diseases, and how well you function with the vision you've got. And this Lancet Global Health Commission eye health cartoon is very helpful because that gives you an idea of how that translates into well-being and inclusion and quality of life. So what data do we have and where does it come from? So some's from government data, some from research, studies and reports, and registers. So there was a government report published nearly 20 years ago that suggested that there were nearly 500,000 Australian children who had some eye health problems, but this was mainly refractive error, and it was perhaps criticised for its methodology, though the number of children that have hospitalisations with eye disorders is probably much more accurate, and that's comparatively a much smaller number. Preschool screening, it's universal in the country, but the methodology is variable. The best documented and studied system is what's called the statewide eyesight preschool screening in New South Wales. It's offered to all 4.5-year-old children, and it's a linear visual acuity. A publication, again, it's 10 years old now, outlines the strategy. So 6/9 or better, you're a pass. That's 80% of children of this age. Miss a couple of letters, you're borderline. They recommend retesting in a year. Not really get 6/9, routine follow-up, that's 6% of the population. 6/18 or less, 2% of the population. And less than 1% were unable to be tested. I put this thing here as sort of a false positive. So of these children that were referred for routine things, how many of them really didn't have an eye disease? It's 10% for the ones that are modest visual loss. For the ones with higher visual loss, the testing is much more accurate, as only 2% were actually subsequently found not to have a problem. And so this is quite effective and useful, and we're trying to adopt this nationally. There were some studies done in Sydney a while ago looking at visual impairment. They unfortunately described it as less than 6/12 across an urban population in Sydney. Very few of these were serious visual impairment. Most of the, well, as in ones that weren't potentially treatable, like refractive error and strabismus. Visual impairment due to serious oculopathology in preschool-aged children in Victoria, in New South Wales is low, does have an association with low birth weight. The Sydney myopia study has looked at use of glasses. Again, this data is fairly old. What I think the most important thing is the bottom line is that there's very few children who need glasses who don't get them. So an affluent country, you can get glasses if you need them. There is a register of visual impairment, children who have vision less than 6/18. It's voluntary, and not that many people are enrolled in it. In keeping with other developed countries, abnormalities in the visual pathway, retina and optic nerve are high up in the lists of causes of less than 6/18 vision in the Australian population. But this is a relatively small number. I mean, there's many more than 800 children with visual impairment, and this was 10 years data for this registry. And that just gives you some idea of the level of vision seen in those children. There's another recently published study that looked at the eye problems in 3-year-olds presenting to a tertiary hospital, and this gives you some idea. And again, it was data collected over, I think, 5 or 6 years of 3,000 children, and these were the causes. Strabismus is in the other category because the WHO classification of vision impairment doesn't have a nice classification for strabismus. And you can see that the highlighted areas there are the ones that relate to the register. I'll just bring it up to this side to compare it. So in young children, visual pathway reasons for visual impairment are similar to what's seen in the register, and that probably makes sense because of their congenital abnormalities either in the brain or the optic nerve, like optic nerve hyperplasia. The rate of retinal impairment in under 3-year-olds is lower, and that's because in older children you'd have retinal dystrophies that take time to be manifest. And interestingly, in that group, amblyopia was much more common, and that makes sense. That's when you're detecting amblyopia. Myopia in Australia, is it the Asian tsunami, or is it calm in Australia? You know, what's happening with that? Bit difficult to get good data, but the Sydney Myopia study has a couple of publications in which they followed people up after a 5 or 6 year period, and that shows that the rates are increasing, but the rates are much lower than obviously was reported in the previous talk. So it's less of a problem. It's probably related partly to sunshine, partly to ethnicity. I think in large measure related to sunlight. The workforce in Australia, there's 1,000 ophthalmologists, but not many paediatric ophthalmologists. In the public hospital system where the training occurs is effectively 16 full-time. I mean, to give you some idea, I only work 1 day a week 2 days a week in the public system, so I'm 0.4. But across the whole nation, there's relatively few. In private practice, probably more. There are many more optometrists, and we have a good supply of orthoptists because there are 2 university schools of orthoptics in Australia. Paediatric eye care, this is not paediatric ophthalmologist, is dotted where the population is. New Zealand sneaks into this one. This is where ophthalmologists are, so very few in Central Australia and other places where there's less people. And there is cause for concern in Australia about an impending shortage of paediatric ophthalmologists for a variety of reasons. Similar to other parts of the world, it's difficult to recruit people in ophthalmology training into paediatric ophthalmology, but we're working on it. So the conclusions I have is that a wealthy nation, we have good resources, so most people who need healthcare can access it, though there can be geographic difficulties and workforce supply problems in more remote areas. There seems to be in children a relatively low rate of avoidable vision impairment, as you'd anticipate. The challenges relate principally to geography and distribution of the workforce and ensuring that we have an adequate supply of paediatric ophthalmologists going forward. Thank you very much.
Yes, any questions from the floor, please?
Yeah, it's a very nice presentation. Just want to also that map. There is a geographical map regarding the I think rural red color, yellow. Can you go to that map again?
Can we have the talk back up to have the map? Can I load the talk again, please? So was it the population or the socio-economic standard? Because both of them were coloured red.
Population, I think.
Yeah, I'm not sure whether they can get it up. Anyway,
okay,
ask you.
By that time, yeah. So whatever the data you presented regarding the school screening, I think.
Yes,
So
the school screening in New South Wales, the thing that they have there that's very well developed is they have what they call local government regional health areas. And the way it's funded, the preschool screening does happen in the remote areas. And in fact, they showed that the uptake in some of the more remote areas was higher than some of the urban centres. And so I didn't have time to present all the data about that particular screening protocol, but the uptake for preschool screening is quite good. Children tend to be in towns and cities, and so if you can visit, even though it's a small town, if you can send someone there, you get most of them. And so they still only screen about 75% of the population that's eligible, so 25% of children don't get screened for a variety of reasons. That number, that was in that publication from 2014. They actually are getting that up. I think they're closer to 80% now on more recent unpublished data. But they specifically have funding to go to the rural areas for that.
Interesting. And second thing was regarding the diseases identified for the visual impairment, that is based on the worst eye only.
Yes, that's binocular visual. So that visual impairment register, it's binocular visual acuity less than 618 or field less than 20 degrees, or they have any child with cerebral visual impairment, because often those children, you can't either document the field or the visual acuity, and so the inclusion criteria for that registrar was best corrected binocular acuity of less than 618 or less, which is consistent with the WHO definition of vision impairment. And that was the problem with the other Sydney study. They, for some reason, chose 612. I suspect probably it was so they could look at uncorrected refractive error and things like that, which is what they demonstrated in that study. Yeah.
Thank you.
Hello, Dr. James. Good afternoon. We all know that the climate can have really bad impact on the eyes of the children, especially when it comes to allergies and all. I would like to know in Australia what is the pattern of allergies and how significant are they?
Yeah, so allergic eye disease is quite common in the city that I work in, Melbourne, because we're surrounded by an enormous grasslands and farming, and so there's a very high pollen load. So allergic eye disease of all sorts occurs relatively frequently. Sight-threatening allergic eye disease is fortunately relatively uncommon, and again, most of those children, because of their symptomatology, access care and get treatment. But allergic eye disease is not uncommon. And then it was, I didn't talk about it specifically, but in that study of under 3-year-olds at the tertiary hospital in Sydney, I think it was 10 or 15% of their patient group had ocular surface disease. Now, some of that would have been infective, but some of it was allergic even in 3-year-olds. Yeah.
Do you take interest in screening for other allergy of the body issues like asthma or any other things also?
Yes, and so in keeping with that, atopy is often a body-wide problem. We've had problems with what's called thunderstorm asthma in Melbourne, where you have these weather events during the pollen season in which a huge amount of pollen is stirred up and basically dumped in the city, and so we've had issues with lots of people having acute asthma episodes with that. Asthma as a disease in Australia is much better controlled than it used to be, and that's again because of a well-funded health system. People can access appropriate suppression therapy for their asthma, and so severe life-threatening asthma has become less common.
Thank you for that.
Thank you, James. Can I ask a question? Wonderful talk. Thank you very much. In Australia, such a big area country with relatively less population, very scattered, are there any role for the digital medicine, AI, in terms of improving the healthcare access or advancement?
So there is some, in terms of digital healthcare, I'm not so much aware of whether AI has been employed here, but certainly during COVID, we used telehealth. We published an article about parental satisfaction about that, and people were very happy with it. I have colleagues in Western Australia who do quite remote care in the northern and inland parts of Western Australia, and they use telehealth there, though it's often in the method of supporting. So there's someone who does, say, retinal photography for diabetic retinopathy or anterior segment photography for cataracts, and then it's interpreted elsewhere. It's not a truly consultative process, but that's a problem that bedevils all telehealth as to how much consultation you can do and how much you can have data for expert interpretation elsewhere.
Thank you. Thank you. Yes.
Yeah, that was a wonderful talk on the eye health, child eye health in Australia. I had this question. So you mentioned in one of your slides about the different ocular diseases of children who presented to a pediatric
Yep.
eye care center, and I think close to 50% of them were normal, and they had come for screening purposes.
Yeah. So the one of the largest diagnostic groups there was, because it's a tertiary hospital, is internal referrals. So neurology sending a patient, do they have headache? Rheumatology sending a patient with JIA, do they have uveitis? And things like that. And in an under 3 population, so that was a large part of the workload for under 3. I'm sorry I don't have better data for sort of the whole range of children in terms of looking at the literature.
Okay. No, I just wanted to check if that would include the uncorrected refractive errors as well. Were they identified?
Include?
Uncorrected refractive errors?
No, there wasn't much uncorrected refractive error there. There was a section on, I thought there was a section on amblyopia, and also in that other section, that's where the infantile esotropia was and things like that. The classification is a little clumsy because it uses WHO visual impairment or sites of disease, and strabismus is classified as other in that, as I understand it.
Thank you.
Hi, Dr. Elder. I'm here.
Yep.
Here, I'm speaking.
Oh, sorry.
from here. Yeah, that was a wonderful talk. It just gave us a bird's eye view of children eye care in Australia. I just had a question on the workforce that you mentioned about. It seemed like the urban areas have a concentration of eye care
Yes.
teams located. And I was curious to know what percentage of population, basically the childhood population, lives in the rural parts.
Yeah.
Are there any?
Yes, so that again was on that graphic of the map. 80% of the population lives within a couple of hours' drive of a major capital city. 20% is a bit further. Sorry, no, take back. 90% lives within a couple of hours' drive of a major capital city, and 10% are more remote. We have a number of initiatives to try and move the workforce more rurally. In our training program, we have rurally targeted trainees who do the majority of their training in a larger rural area, and they hopefully will practice in more remote areas. Most of them are as general ophthalmologists. We only have a handful of paediatric ophthalmologists who practice outside major centres. We have a few, but not many. That's a difficulty. So it means that children who are remote, I mean, in my clinic, I would have children that have travelled 6 or 7 or 8 hours to see me. Because there isn't an appropriate
Do you have
paediatric
any information on the availability of care or the need, the difference between the needs among the urban children versus the rural population?
The needs are probably similar because it's a fairly uniform. I mean, we probably see more myopia in the urban population, just as you'd expect from all of the other studies. So my refractive error is probably more common in the urban population. Other than that, I don't think there's a lot of big geographic difference, except perhaps with the remote indigenous population, because trachoma is still exists in Australia despite many efforts to eradicate it, and so there would be a small number of children in very remote Australia who still have trachoma or at risk of it.
Okay, thank you. Thanks everyone, and now moving on to the next talk, I would like to introduce Dr. Sumit Grover from All India Institute of Medical Sciences to talk on low vision and rehabilitation aspects of vision impairment in children.
Thank you so much, Winston. Respected Chair, and good morning to the August gathering here. I'll be presenting about the low vision assessment and rehabilitation aspects of child health, and there are no financial conflicts of interest. So we all know that this slide shows the WHO classification of visual impairment and blindness, and the term low vision, which was previously was there in the classification, has been replaced by categories 1 and 2. But what we are, the slides are not moving. But what we are interested is the WHO functional definition of the low vision, which states that the person who has visual acuity of less than 6/18 to the perception of light, but who uses or is potentially able to use the vision for planning and execution of tasks, which is the residual or the functional vision. And because of this definition, the people who were initially were categorized as blind now comes under the purview and the services to be offered to these people, low vision services to be offered to these people. As far as the prevalence and causes of low vision, prevalence of low vision in India is concerned, according to a study which was done in the southern part, the low vision was 2.9%, and the primary causes of low vision were refractive errors, which were of course mainly in the children, and the cataract in adults. These are some common diagnoses which we see. Perhaps this is a common scenario in the southern part of the India as well. So basically it's a whole globe in the retina, congenital disorders, retinitis pigmentosa, atrophic bulbi, high myopia, pathological myopia and its consequences, squint, congenital glaucomas, and then cortical blindness as well is on the rise. These are some clinical pictures. And when we, this is something which is interesting side, that when we analyze the cause of visual impairment from last four decades back, when we started our national program for control of blindness in 1976, when trachoma and cataracts were the main problem, and now when we look at the current scenario, the complex problems are here: ARMD, pathological myopia. So there are increasing complexities of the problem, and the resources requirements and the multi-sectoral integration is required. So that is how we are evolving, and that implicates that how these low vision and rehabilitation becomes important. So now, when we come to the assessment of the low vision, it's very brief slides and a very brief overview of this I'll be explaining. So first, when the child or a client enters into your clinic, we start from the history, and then we do the extent of the vision, near and distance visual acuity. And I want to emphasize that we have to be objective as much as possible. Like for example, we the optometrist or the ophthalmologist in the clinic, we tend to write the visual acuity in terms of finger counting, hand movement close to face, but it's okay, but we have to go objective. Like you should use the Leah vision chart or the Cardiff. As far as possible in these clients, we should objectify the visual acuity, and then size of the visuals as field by the confrontation method or the Goldman perimetry. Then what are the effects of light and glare on their eyes, on their working, extent of recognition of the faces, naming of the colors, and then extent of the use of vision for their activities of daily living, the purpose of their environment, whether they are in school, whether they are at their home, and extent to which the person sees and recognizes an object depends upon other factors as well, the familiarity of the object, light, size, distance, etc. And last but not least, the age, socio-economic condition, literacy status of the parents, and level of motivation of the parents is also very much important consideration. So when we do the best surgeries and everything, like beyond the best treatment, when the patient comes to us in the low vision clinic, so we should go for the history, which is very important. I have already mentioned that. Then the visual acuity, visual field, refraction, color vision and contrast testing, again on the objectively on the Pelly-Robson chart, and many other D15 color vision testing. These are very important. And then we move forward to the low vision aids, trial of low vision aids, and counseling and education of the family and teachers, of course. So this is, sorry for the busy slide. This slide shows that how we start or approach a patient for the low vision devices. We should begin with the distance vision devices, like for example telescope, and then we move to the near optical device trial, and we should record the best visual acuity and there are many methods of estimating the magnification of a particular for the particular child, and I'm not going to going into the details, but there are many formulas for that. And let the patient demonstrate the improvement of vision with each type of devices, and then we should take the comments on its utilization, the ergonomic, how the child is able to use or like kind of carry that low vision device. And then iteratively we should give another options to the child and the parents, and many a time such option may not be taken in one examination, so the repeated follow-up should be considered. And these are the this is overview of some basic optical and non-optical low vision devices, and like telescope, reverse telescope for the as a field expanders, then magnifying spectacles, and there are some advantages and disadvantages of these magnifiers, and there are hand magnifiers, stand magnifiers, illuminated, self-illuminated, etc. So this is the slide which shows the it's not working. Anyways, so this is the slide showing the self-illuminated hand magnifier. Then this is stand magnifier, in which the hands are free, and this is the okay, thank you. And bioscopic telescope, which is very much useful, and in some parts of the US it is also being permitted for the driving as well, and it is very sleek and can be fixed on the spectacles of the child. And then very important, these are electric magnifiers which come in various forms and sizes, and these are very helpful, and nowadays many smartphones have replaced them for their usage. And now if we come to the low vision rehabilitation part, actually rehabilitation is an umbrella term in which the low vision devices prescription also comes, but just to compartmentalize from the low vision devices, now we are coming to the low vision rehabilitation. And in this purview I would like to talk about the non-optical devices like filters. Many a times we just focus on the low vision devices, but we forget about the effects of glare and especially in the albinism and RP patients, so, and role of controlled illumination, and then some kind of assistive technologies or products like typoscope, Notex. These things also should be offered to for the child, and all these are based on the principle of big, brighter, blacker, and the closer color and contrast. Then there are mobility devices like canes and smart canes with the Bluetooth devices connected to the stick, and it can tell the child that how far is the obstacle, and the child is able to navigate smoothly. Then there are many medical assisted devices like talking watches, sensory substitution devices, and large print phones, large print playing cards, etc. And these can be locally made or can be purchased, and even the school teachers can modify the textbook and the things for the students in the school. Then the role of smartphones and the apps is worth mentioning, and most importantly the environmental changes. Now we have a concept of inclusive schools, like a child with a visual impairment should study in a normal school, and the school has the responsibility to make it inclusive for that child. So there should be the braille writing should be there, for accessibility there should be ramps should be there, all these things should be included. And then orientation and mobility training is very important, and the objectives are the safety of the child, independence, the privacy, the gracefulness. Sometimes we see the child with the severe visual impairment or the blindness, they're not able to make when they sing or they just speak, they make different gestures in these things have to be taught to their parents, and these things should be highlighted and make aware that these are also by the training can be improved. And then these are some principles of the orientation mobility training, and these are like we have a very good guidelines made by Dr. RP Center AIMS, and these can be procured from as a soft copy, and very important in these orientation mobility training. Now, especially in the children with the visual loss, we know that vision play a central role, and severe and profound visual loss affects the behavior and development skill of the child, cognitive function, socio-communicative abilities, then formation of social relationship with other peers, and education and employment. And vision rehabilitation in children needs attention as a, like we have two sets of intervention. One is vision stimulation. It improves by enhancing and changing the anatomy and physiology by stimuli in an artificial surrounding, like use of flashlights, use of many video games, etc., vision therapies. And but the results in the many studies were inconclusive, ambiguous, and very minimal responses are seen, because they tend to change like the neuroplasticity between the ocular structures, retina, and the brain. But the functional vision training is like the rehabilitation part, when we give some objects to the child, make them familiar that this is the block, this is the card, this is your shirt, this is how you have to put on the buttons, etc. This is like sensory substitution. It is visual function training, which is very important for the child. This slide shows the RP center model for rehabilitation services. At the hospital, which is our tertiary care hospital, we do the secondary and tertiary rehabilitation in the form of medical and surgical interventions. And then training and retraining of assistive devices is done in a separate wing, which is low vision rehabilitation wing on the 7th floor. We do activities of daily living training and orientation and mobility training. And then we have a social wing. There are spans of 17 vision centers which are spread across Delhi. And we do networking with the NGOs and schools for the blind and community-based rehabilitation through our primary eye care centers. So this is called the medical socio model, which is being implemented at our center. And just two more slides about the assistive technology, that how we classify this assistive devices into two types at our center, based on visual, tactile, and sound based, and we classify them according to the visual acuity cutoff. Like for example, if a student has visual acuity of less than is more than 1/60, is with binocular best corrected visual acuity, so they are potential beneficiaries of assistive technology based on visual skills such as optical aids and large print books. But those who have less than 1/60, we give them assistive technology based on body sense using the functional vision learning. And these are some literature which is freely available in our in the website of Dr. RP Center AIMS. And last but not least, just a few things about the these smart glasses. I want to just show one thing. That this girl came to our low vision clinic, and for the first time she was able to see the face of her mother after so many years, and that was very much gratifying experience for the mother. It was very emotional thing for us. For the first time she was able to recognize the face of her mother, and this was possible because of the central vision loss onyx device. And this is the cost effect, like for the general population of India it is a higher thing, but now it has come down to 1.5 lakhs only. So that the purpose of these slides and to highlight these smart vision glasses, that there is a hope, still the hope, and we can counsel our patients and parents that they should not lose the hope. And sometimes it is by reflex or something like that. As a clinician, I'm also an ophthalmologist. As a surgeon, we say that nothing can be done now. Your vision is lost. You have a foveal dystrophy. Nothing can be done. You have the RP is there, advanced RP. Nothing can be done. So that is not the end of the life. We should instill the hope in the parents as well as the child that there is many more things to done. There are low vision devices. There are low vision rehabilitation is there. Orientation mobility training should be given to the child, and the community-based rehabilitation should be done given to the child. And we have many assistive devices, assistive technology. We have smart glasses. So we should instill the hope in the child as well as the parents. So that was the crux of my presentation. Thank you so much for your patience.
Thank you, Dr. Grover. In the interest of time, I think we'll take the questions for him at the end of the next
Sure.
couple of sessions.
Thank you.
Yeah. So I'd like to invite Dr. Rebecca Smolany to speak on CVI incidence, screening, diagnosis, and management.
Thank you for the invitation to be part of this session. So I'll be talking about, while we are still staying on the pediatric visual impairment and also talking about the rehabilitation aspects, we'll dive a little bit deeper and talk about not just ocular causes of visual impairment, but about the neurological causes as well. So as rightly mentioned, I'll be talking on CVI. I have no conflict of interest, although I'll be telling about few techniques and tools. And I'll start off with this powerful statement by someone who's revered in the field of CVI, Dr. Gordon Dutton. He goes on to say that when you met one child with CVI, you met one child with CVI. What does he mean by that? Just that the generalized, it's not easy to generalize the condition because of the varied presentations of children in this specific cohort. There are various definitions for CVI. The most commonly used ones are what I've highlighted here. It's a verifiable visual dysfunction which cannot be attributed to disorders of the anterior visual pathways or any potentially co-occurring ocular impairments. It's also a neurodevelopmental disorder characterized by deficits of visual function and functional vision, and that are caused by neurologic damage to visual pathways and processing areas in the brain. So both the definitions essentially are saying that CVI is beyond the ocular realm. Right? So the most common ocular conditions that are noted in children with CVI include the uncorrected refractive errors, squint, cataract, and optic atrophy. The reason why I've highlighted optic atrophy, because it's very commonly seen in children with CVI, both partial and full optic atrophy. This is because it's a retrograde transsynaptic degeneration that is seen in these children. So it's not just ending at the occipital lobe, the damage extends towards the parietal lobe and also towards the temporal lobe, and children with CVI can have difficulties with visual spatial awareness skills, with visual motor integration. A simple eye-hand coordination task can be very challenging for these children. Motion perception, even a basic task like recognition of shapes or sizes or faces can actually be very challenging. And even perceiving two or more things at a time, especially when the child has to spot the mother in a group of parents, the child may find it to be very difficult. Why are we talking about CVI? Because it's on the rise. It's the leading cause in developed countries, and it's rapidly increasing in developing nations as well. CVI often gets undiagnosed or underdiagnosed. This is clearly due to lack of awareness among key stakeholders, including clinicians like optometrists, ophthalmologists, rehabilitation professionals, neurologists, pediatricians, and so on. There's challenges in assessment, I'll come to that, and also inadequately trained clinicians. Additional developmental delays can add to the complexity of the condition because the focus shifts to the more obviously affected developmental milestones. Like, for example, a child is not able to walk or the child is having difficulty to talk. That can get more focus than the child having vision concerns. So the focus shifts to the more difficult concerns, and also medical issues like seizures. So if I have to give you a global picture of CVI, I'm afraid I do not have much data, as there's scanty literature out there across different countries. But I found these to be the most prominent studies. The first study from India, we had 33% of children who had major cause of profound visual impairment in less than 3 years of age. That was found to be in the southern part of India. And in another study in the southern part of India, we see that 70% of children had CVI. This was the most common cause in children studying in special schools, not special schools for the blind, in the other special schools. And we also have a study from UK which points out that 1 in 30 school-going children have at least one CVI-related vision concern. And from the US, from the various data, the Perkins International website mentions that over 180,000 children are estimated to have CVI in the US. And we have some data from the West African countries as well. 2 to 3 to 7% of children in the pediatric vision impairment group have CVI. And we also can take the data from Australia, as mentioned by Dr. James Elder, around 1.8%. And looking at the incidence, this is data only available from the US. You can see the data ends at 2003. There's no recent data after that. 36 per every 1 lakh children in late 1980s, which is now grown, not now actually, in 2003, which was 161 per every 1 lakh. What are the causes of CVI? The top 3 in the list are the actual most commonly seen causes. One is the hypoxic ischemic encephalopathy, periventricular leukomalacia, neonatal hypoglycemic brain injury. There could be genetic causes as well, metabolic disorders, and trauma. So this is a clear call for good antenatal and neonatal care, especially if we are to avoid the top causes of CVI. And how do we go about diagnosing CVI? It's not very easy. These are the three most important parameters that are used by pediatric neurologists and pediatric neuro-ophthalmologists that include the birth and the development history, visual behavior, and the visual concerns that is observed during the examination or as reported by the parents or primary caregivers, and more importantly, the neuroimaging findings. Birth history, we all know the conventional birth history. We also need to check about their neonatal complications like hypoglycemic insult, jaundice, meconium aspiration, respiratory distress, hypoxic insult. In one of the in-house papers by our team, we found that 50% of children with CVI had etiology of neonatal hypoglycemic brain injury. And all of the parents invariably reported that the child did have a hypoglycemic insult in the neonatal period. Also, it's important to dwell on the maternal health as well, like gestational diabetes, hypertension, any chronic illness during the pregnancy, or trauma, or any event of miscarriages. These are the important birth history that you would look at. In addition to birth history, we also need to concentrate on the developmental history, not just the visual developmental milestones. You have to concentrate on the other developmental milestones as well. So an easy to remember mnemonic would be 1 for walk, 2 for talk. If the child has not attained these milestones over, as past the age, so it should raise a red flag, and you need to refer the child to a developmental pediatrician for further assessment. Looking at the visual behavior, here are the 10 most commonly and unique characteristics that are observed in children with CVI, ranging from need for movement, there is specific visual field preference, there is visual latency, non-purposeful gaze, the child would just be looking towards a light, having a light gazing behavior, absence of visually guided reach, and so on. So while proposing these 10 unique characteristics, there's a way to assess that and actually understand what is the severity of CVI like. We also have Gordon-Dutton's CVI inventory scale. Here it is ranging from, for the age range of children from 4 to close to 12 years of age, this can be used. Simple questions are given here for your reference. These are all available on the Ulster University website. Does your child trip over toys and obstacles on the floor, trips at the edges of pavements going up or down, and simple questions like this, which can come in very handy when you're assessing the extent of CVI. Visual concerns, when we had carried out an in-house study, we found that children with CVI, the parents of children with CVI reported 14 unique visual concerns that are listed here, including difficulty in recognizing faces and maintaining eye contact being the top 2 causes. And a very interesting finding that had come out from the paper, when we had clubbed those children having recognition of faces and eye contact in group 1 and had the other group with other concerns, we found that both functional vision score and the contrast sensitivity score was actually significantly lower when compared to those who had other concerns. So this again clearly says that when children with CVI come to the clinic, it's very important to check for their eye contact, whether they are able to maintain eye contact, whether they are able to recognize faces. And if parents are not reporting by themselves, it's important for us, to proactively look for it. Neuroimaging findings, studies clearly point out that visual cortex could be damaged, and particularly optic radiations, this could actually be an early predictor of CVI. And Sioni et al. In this paper goes on to mention the different grading that can be used to understand the location and the extent of CVI. So in order to diagnose CVI, not just the 3 parameters, there's a way forward to go much more deeper, like having a comprehensive vision assessment, visual perceptual assessment, clinical electrophysiology, and a neurodevelopmental assessment. How do we go about screening them? It's not easy in a busy clinic to run a 50-item questionnaire, right? So in order to screen for CVI, Gordon-Dutton proposes this 5 questions that can be used, and 3 out of 5 scoring that comes out positively on these screening questions, then you need to go ahead and comprehensively assess the child. So I'm just going to propose 4 important clinical pearls that you could remember while assessing and managing children with CVI. Pearl 1 would be children with CVI may have several functional vision challenges despite good visual functions. What do I mean by that? So let's have a look at this video. This particular child was an acquired case of CVI, had binocular visual acuity of 20 by 30, and you can find the difficulty that she has in this video. So a simple task like of matching shapes on the Leah 3D puzzle was very difficult for her, despite having a good visual acuity of 20 by 30. Now this happens in cases when there's higher order visual processing disorders. And we also see the same child had difficulty in recognizing facial expression. So my task that I gave it to her was just pick up the card which has a happy face. And the child was actually struggling with it despite having a 20 by 30 visual acuity. So this clearly shows that their children with CVI do have higher order visual processing dysfunction, and they need to be checked for those. Behavioral issues again are very common in children with CVI. You know, the child may not be wanting to look at your grading acuity tests or, you know, the letters that you put up. Even looking at the balls can be very challenging. So then how do you go about it? Assess using less cognitively demanding clinical tools. A 10-year-old child comes, do not assume that this child may be very familiar with letters and just put it on. Check for the child's familiarity, look for the interaction, what they have with you, and then if needed, come down the hierarchy and show easier tasks, like for example, the grading acuity test or the matching acuity test. We also have an app called the Peekaboo Vision application.
Very good. Very good. You should wait now, okay?
So as you see in this app, it's quite interactive that way for the child to follow through the test, and very encouraging for the child to perform the test. In other than acuity, you would also like to concentrate on the contrast sensitivity and the visual field as well. Objective refraction and amplitude of accommodation cannot be ignored because this definitely needs to be addressed. We also have the SANET Vision Integrator, which is both used as a diagnostic and a therapeutic tool. I'll just play this video here. So this particular tool, the SANET Vision Integrator, is used both for diagnostic and therapeutic purposes for understanding the child's eye-hand coordination, visual spatial awareness, attention, memory, and etc. So after we advise for the therapy, we can also monitor the progress of the therapy sessions using this device. And functional vision assessment definitely is the key. Even a simple task like, you know, asking the child to reach towards the ball and see how the child is reacting to it. And it's important to mention if there's any latency or, you know, the object characteristics, the contrast, distance, and the room illumination. So looking at third pearl, oftentimes simple assistive devices may provide a solution to the complex visual needs. We had a great talk by Sumit, who just mentioned about the different devices that are available. So telescopes, magnifiers cannot be ignored in these children as well, especially those who are having academic demands and are high functioning. And a simple material like a typoscope can actually declutter the reading material and help them focus only on what is to be read. And a magnification app like this is called the VZoom app, which is actually freely downloadable, that can be used even for your pediatric visual impairment group as well. And devices like alternate augmented communication for children who are pre-verbal or non-verbal. Coming to the last pearl, you may need to plan beyond a one-size-fits-all approach, especially when you're dealing with children with CVI. Customizing your rehabilitation plan is very important. Consider the child's visual functions, the functional vision developmental milestones, and it's always important to have the parents and the primary caregivers part of your counseling sessions, especially because rehabilitation management can be long-term, and in order for them to sustain and be on the same page, it's important to have all the primary caregivers as part of your counseling session. And in addition to what I've just mentioned, also it's important to co-manage these children because they may need occupational therapy, speech therapy, physiotherapy. So it's important to co-manage them with the rehabilitation therapist. So what are the key takeaways? CVI is a growing public health concern even in developing countries. Scanty literature as such exists on global stats on CVI. So definitely this calls for large and multi-centric epidemiological studies. There's a need for research focusing on evidence-based rehabilitation strategies and a clear need for interdisciplinary approach. So yeah, thank you.
Thank you, Dr. Sumalani. Again, in the interest of time, we'll have the questions at the end. And now call upon Ms. Minh Anh Tran from Vietnam to speak on the status of vision impairment in Vietnam.
I think it's to say good morning, but good afternoon, everyone. It's been a wonderful, thank you so much to the organizing committee for the invitations. It's my pleasure to be here again. Why again? Because 12 years ago, I actually was in the first APAO of my entire life at that time. I was a baby at that time, I could say, a baby optometrist who about to graduate from Bachelor School of Optometry, Viprasad. So it's my honor to get back here. Namaskaram, everyone. Yeah, so today, to continue with Professor Saw as well as the Dr. James regarding about the screening and the status of visual impairment and refractive errors, I want to provide a little bit of the picture of Vietnam. So I have no conflict of interest, although I'm academic lead of one of the university in Vietnam, so we receive many sponsors and support from many other companies. However, regarding to this, we do not have any conflicts of interest. So I will go through in this talk a little bit about the Vietnam population so you understand a little bit about us, and then an overview about vision impairments and refractive error status in Vietnam at the moment, and then a little bit, a very small picture of the eye health screening that we are doing at the moment in Hanoi Medical University. So talking about Vietnam, Vietnam is a Southeast Asia country lying in the light, very small S letter over there. We have 101 million, with 40% of the population living in the urban areas. So we share the feeling of Dr. James and of course Professor Saw regarding how people are just dominantly living in the urban area. So it also feel like becoming the capital of myopia, secondly after the Singapore. So the average age right now is 32.9 years old, and every day we have more than 3,500 children born. So it's quite young country, and we have 25.2% of the population is under the age of 15 years old. So talking about visual impairment, I've been looking at papers in Vietnam. However, we only have very few papers that have been published talking about the visual impairment prevalence that is powerful enough to be able to present. So this paper was actually done with the support from the Brian Holden Vision Institute in 2014. The data was collected in 2011 in the beautiful city called Bà Rịa Vũng Tàu in Vietnam. One of the beautiful places that you can visit if you have any time. So you can see that the prevalence of visual impairment in that city is in that province is 12.19%. And in that, 0.3% of cases are blind, 0.09% are due to cataract, and 0.05% due to retinal disorders. And then you can see that the higher prevalence of myopia is much higher in the urban area. So we have subsequently, studies that been done in 2021, 2022, that's showing that the myopia prevalence in urban areas can go up to 53.2% and a lot lower in the rural area. So this study also, they look at the risk factors, and one of the risk factors that was top listed were actually the maternal education. So the higher standard the mother has go for the education, the higher chance that your child is having myopia. So that was what is concluded from our study, from our Vietnamese study that done over the past 10 years in Vietnam. And parental spectacle use, aka the refractive errors. So we already know this. Parents having myopia increase the risk of myopia in the child. New work, as many other Southeast Asia or East Asia, we have a very strong education stress. So that because of that, students read a lot and having a lot of reading habit that cause a lot of problem with the myopia. And urban locality, you can see that the more they stay at the local area, the urban area, the worse their myopia can be. And of course, higher grade level, as we know, once the child have myopia, they start growing. So then, the prevalence of myopia start increasing later on. So you can see that here I put the two strongest paper together to show that in 2014 in a very beautiful city nearby the beach, you can see that the urban area, they have only 26.6% of children having myopia. And then in the urban area, in the years of 2021, when they did it in 3 different other locations, this number doubled. And then you can see also myopia prevalence depending on age and gender. So in age, the higher the age, the more patients have myopia. And of course, genders, we have more female students have more myopia compared to male. And this, I think, is very correlated with many studies that we already are aware. So now we know younger the kids have myopia, female parents have myopia, or other known risks. And we found a similar picture in Vietnam. So what I'm here today to talk about the children eye health in Vietnam. So we have something called the Vietnam National Prevention of Blindness Strategic Plan. This plan was to aim until 2020 and have the insight to 2030. So in that, our government already identified refractive errors as among the key areas to be addressed to reduce the burden of avoidable blindness throughout the country. However, the eye health in children has not been officially included in the school health curriculum. And in Vietnam, children health is systematically evaluated through the Joint Circular Regulation for School Health Service. However, when they come to the eye health check, they only do visual acuity. And as we have just listened to Dr. Rebecca's presentation, you can see that visual acuity alone cannot tell you whether the child functioning well or not. And of course, we will be missing out on the data of the hyperopia on that cases. And currently, eye health, and then because of that, we thought that maybe we can do a little bit better in that. So Hanoi Medical University is now one of the only 2 schools of optometry in Vietnam that offering optometry. We started the program in 2015, and so far we have 450, and this June is going to be 500 optometrists, serving the population of 100 million people in Vietnam. Of course, you can ask what happened with the eye health system in Vietnam. We have another 2,500 ophthalmologists and a couple of thousand refractionists supporting us. However, there's been a big gap in between, ophthalmologists and the refractionists and nurses in Vietnam. So the objective of this program was to have the early detection and intervention for the kids, as well as have the community engagement, increase the awareness for the patients, for the parents and teachers. And then after that, utilizing this collected data to inform health policy and advocate for improved eye care strategy in Hanoi first, and then subsequently in the whole Vietnam. So we run subsequently many screening in Hanoi, the years 2022, 2024. Why? Is because we have COVID during the past, before that for a few years. So then we start doing that again, and we start collecting on data. So I'm going to give you a little bit of insight on that at this moment. However, there's about to have the systematic review published soon by one of our colleagues that's doing her PhD in UK. So in this, you can see that 29.9% of our students in one school was having refractive errors. And if you look at the whole school, every 4 kids, we have 1 kid that have myopia. So that is in primary school of the urban area. And when you look at Hanoi continuously, we have done the other school. And in this kind of health eye examination, we do not stop at the visual acuity testing. We do all of the comprehensive eye examination for these patients. But for this purpose of presentation, I will stop at the prevalence of the refractive errors at the moment. So you can see in the secondary school of the same urban area, the numbers have jumped up from 65 to now 83 of the children. So we continue to do it in another high school, but high school in the center of Hanoi, they are very busy with their education training. So usually they will refuse to have the screening that with cycloplegic. So that would be one of the key problem in Vietnam, that we cannot cycloplegic everyone for the screening purpose. After that, we did one suburban high school. And then you can see that in the suburban area, this number is not too high, but still very much higher than the number that been published by our whole nation information. So 63.5% of our children in high school have refractive errors, and 58% are having myopia problem. And you can see the number of eye diseases are there, but not too high. And one of the problems that we found in our patient who wearing glasses and who are having a refractive errors is the rate of incorrect prescription glasses use. So this, because I'm not sure whether it's Indian having the same problem, but Vietnamese children usually used to have a lot of accommodation spasm. And then they just use autorefractors, at many optical shops. And then because of that, we've been prescribing wrongly glasses for many of the children. And then one of our recent publication by the Ministry of Health showing that the rate of incorrect glasses nationwide was 65%. So that raised a very big questions about how we're gonna treat this patient correctly if you not be able to prescribe a good pair of glasses for patients. So in overview, you can see that children in Vietnam show variable burden of refractive errors and vision impairment, and myopia is the most frequent report conditions, and high myopia rate in urban area can go up to 40, 53, and we can see right now in certain schools it can go up to 80% of the children. And then we have lower myopia rate in rural area that was explained. Maybe we should change, the environment, behavioral, like Professor Saul suggests at the beginning. However, every parents would push the children to study so hard this day. And you also can see that the study has shown the number has increasing, and the rate of children not wearing correct prescription glasses in Vietnam is still very high. So then my last slide would be, what can we do to improve this? So I listened to Dr. James and I realized that we need a lot to learn from everyone. First of all, we need more screening, like more thorough screening with a very good quality screening as well. So we need a protocol, a guideline that everyone stick to that guideline and follow it. And then we also need a better refraction service team. Because right now in Vietnam, if you are going to any kind of the glasses optical shop and then you get wrongly prescribed spectacles, that's going to be a waste of time and increase the awareness of the public. I'm a myopia management person. I love to do myopia management, but one of the concerns that I always get is when my child get worse if they continue to wear glasses, and they just want to go glasses free all the time. So then, if we can increase the awareness of the public all about, hey, wearing glasses is not that crazy. And, I know we've been talking about atropine, we've been talking about stylus dims and all of the fancy equipment, talking autokeratology, soft contact lenses. But come on, there are children that have visual impairment due to uncorrected refractive errors. So my last talk, so I hope that it's not take up so much of your time. It's my pleasure to be here today, and thank you so much for your listening. Yep.
Sorry, that was a fantastic talk, Mingyang, and I've got a couple of questions. Is there anyone in the audience who would like to ask questions?
Dr. Min, thank you for that wonderful presentation. The percentage of refractive errors, what you have shown us, is it typical for your country, or is it the same in the other Southeast Asian countries as well?
So I think one of the difference in Vietnam and many other countries in surrounding area is also the urban locations. So you can see that from Singapore, as Professor Saul speak at the beginning of the talk, the number of refractive errors, especially myopia, is much higher in those countries. So this prevalence is applicable only for Vietnam at the moment. Yeah.
And one more question. In the slides which you have shown us, the percentage of myopic astigmatism is more combined with the myopia and hypermetropia. In the last few years of my clinical practice, even I have the same findings, but I couldn't document it. Is there a shift of refractive errors from myopic to astigmatism?
I don't think there's a shift in myopic into myopic astigmatism, but I think that there's a collected data to talk about astigmatism. And one of the clinical findings that I found normally is the child usually wear higher prescription, like they adapt to the astigmatism power and require a little bit higher over time, but it isn't the progression of astigmatism. It's just something that they didn't wear at the beginning, but then they eventually need when they increase demand for reading. Yeah, so that's what I found. I think there's an report data on the astigmatism power.
Is there any guidelines from the government to combat this surge in myopia from your side?
Sorry, compare.
Is there any guidelines from the government sector to combat this increase in myopia apart from the reduced screen time and outdoor activities?
Not at the moment for us. Yep.
Thank you.
thank you for an excellent presentation. One thing, it's sort of more a comment, I didn't point it out closely in my presentation because there was too much data, but in the Sydney myopia study, when they looked at refractive correction in 12-year-olds in an urban population in Australia, they found 17% of the children wearing glasses didn't have refractive error. They were wearing extremely low plus glasses for perceived reading difficulties or concentration difficulties and things like that. So it's interesting, there's a balance between, as you point out, a huge number of children in your country that have uncorrected refractive error, but when refractive correction becomes readily available, you can get a tip of the slide going the other way, and children apparently needlessly wearing glasses. You know, the reasons behind it are probably complex, but it was a very interesting and difficult to explain observation in that study, that in an affluent country you have a significant number of children wearing glasses for non-ocular reasons.
That's a fantastic, point Dr. Elder discussed about. And thinking about it, I can recall an instant where, we went to, 17% of children who had glasses really did not need them. But on the other hand, one of the vulnerable groups that's been, people don't usually talk about it is special schools, where children with special needs, they study, When we, we did the refractive error screening, and we found about 70% of these children had refractive error, only 4% had spectacle, correction. So there is sort of imbalance. We readily, provide care for children who are, in the mainstream schools, but whereas in the children who are in special schools are ignored. And coming back to you, I just have a question. You presented, the prevalence data on vision impairment and refractive error. I was just curious to know, are there any information on the eye care workforce to provide pediatric eye care for children in Vietnam?
Yeah, so the primary eye care workforce for children in Vietnam at the moment, including pediatric ophthalmologists and refraction, I'm not sure whether call them refractionists / ophthalmic nurses. I've been trying my best, and of course along with all of the institutions in Vietnam as well as NGOs to kind of providing the optometrists. But so far we only have 450, about to go up to 550 this July when we graduate them. Then this number is still very tiny later for becoming the main source for providing eye care system. So we have 2,500 ophthalmologists and I think couple of up to 7,000 opticians. However, you can see the quality is very not very competent at the moment. We're trying our best to improve that and hopefully be able to present you with much promising data in the next few years.
We can also take questions for the other two speakers, if there are any.
You mentioned about cycloplegic refraction in the screening part. So in the screening, what is your screening protocol you are just doing?
Yeah, so there is no strict screening protocol for children in Vietnam. So it's really depending on the school, on the team to decide what they want to do. So because this screening is part of my institution training program for optometry and ophthalmology students, so I have the privilege to work with both of them. So then because of that, this is like a wonderful opportunity for them to learn their responsibility as well as to be able to go to the placement, like to community and do all of the workup. So what we do is, prior to our study, we send all of the consent information, data collection questionnaire to the parents. That will be distributed by the class teachers. We went to the school, we trained the class teachers, what is refractive errors, what is ocular surface disorders, ocular disease, what is there, to look for, what is the symptoms, signs, symptoms, and things like that for the teacher. And then on the day that we're coming over, I will have auto-refractor ready because they are not allowed us to do cycloplegic on site. When you go to rural area, of course, we can still do it, but because we're doing the screening inside the city and suburban area, so it's not very justified for us to do the cycloplegic over there. So then we went to there, we bring all of our equipment. So we start from refractometer. So we have an auto refractometer, we have slit lamp, we have trial frame, we have trial boxes for a couple of the trial, for lens matters, everything. Of course, even some of the time we have to board over all of the intraocular pressure measurement as well, and eye care and your fundus camera sometimes, not very common. And then after that, we put all of the children in line, and then we start measuring visual acuity. We do the Brilliant test, so including EOM, including NPC, including accommodation to find out any problem. And then we do the eye examination to conclude. After that, the report will be done, we send back to the teacher send it back to the parents, and then we will start receiving patients from that to our clinics. Yeah.
So in the clinic you do the cycloplegic?
Sorry?
In the clinics you do the cycloplegic?
Yes, in the clinics, under the medical organization, we are allowed to do the cycloplegic. Yes.
Okay, thank you. So one question for Rebecca, if you can do. So in that CVI group, we see that there is a refractive error is also. So in your practice, how you deal the refractive error correction for the CVI children?
So yeah, you're right in saying that uncorrected refractive errors are very prevalent in children with CVI, and we definitely go ahead and do a home-made refraction, given that cyclopentolate in some children can trigger off seizures. So we go ahead and do a home-made refraction. Looking for a subjective response from children with CVI is next to impossible. So it should be a trained optometrist or a trained eye care professional who handles the objective retinoscopy very clearly. And if the child is able to respond, we go ahead and do the acceptance, or we go with our objective value. And the compliance rate, we see that at least during the therapy sessions, we ensure. Many of the parents say that my child is not interested in wearing the glasses, the child just removes the glasses and throws it because of the behavioral concerns also they have. So what we mention is, at least during the therapies you start it off, because when the speech therapy goes on also, it's important to recognize the lip movement of the therapist. So that also again is a visual cue. And then vision stimulation, obviously, for occupational therapy, because all of these have the vision component of it involved. So we tell them as much as possible, start off with the therapy usage, and then once it is done, then you can slowly prolong it as the child's compliance is. Yeah.
Okay, thank you. Thank you for that discussion, and we can have discussion later. Can I call on all the speakers to come forward for a photograph? You can discuss after the session. Next session is going to start. Yeah.